Welcome back to another insightful episode of MedSynapse podcast series. I'm Hetvi Shah, your host. And today, we are honored to have Dr. Riza Ibrahim join us again. Dr. Riza is a renowned consultant vascular and endovascular surgeon with over 25 years of groundbreaking experience in managing complex vascular conditions. His extensive training from top centers in the UK and an impressive record in vascular care across UK and Dubai has made him an expert in the field. And he is also a proud member of British Society of Endovascular Therapy and Vascular Society of Great Britain and Ireland. And today he'll be sharing his insight on diabetic foot, a crucial and multifaceted topic, particularly with the rising global prevalence of diabetes. We will explore diagnostic challenges, surgical decisions, and patient centered approaches to prevent reoccurrence. So, Dr. Riza, we are honored to have you again with us.
Thank you, Hedvi. Thank you for that kind introduction, and thank you for calling me to discuss a very important and widespread problem.
Thank you, Doctor. Now, let's just dive right into the core issue, Doctor. So, could you start by describing the pathophysiological challenges that diabetic foot patients experience, especially when it comes to vascular and nerve damage?
Yes, so diabetes, the people with long-standing diabetes have a particular problem which affects their feet, and that is mainly due to two different reasons. One is what we call as neuropathy, that is damage to the peripheral nerve because of long-standing diabetes. And the other one is called ischemia, that is a lack or reduced amount of circulation in the arteries down to the legs. Now, the neuropathy, as we know, nerves are of three different kinds. There is the motor nerves that supply the muscles and make them contract. There is the sensory nerves that take sensation back from the foot back towards the brain. And obviously, there is also what's called the autonomic nerves, which are to do with sweating, with sweat glands, etc. So in diabetes, I'll talk about the nerves first. All three of these different types of nerves are damaged. And how does that individually affect the foot? So when the motor nerves are damaged, the nerves that supply the small muscles in the feet, the interosseous muscles, etc., don't work very well. So you end up having a change in the shape of the foot. You get things like the toes clawing, the collapse of the midfoot, and changes of shape that leads to changes in pressure distribution when somebody walks. So normally the pressure is in certain points, but when you start having these clawed toes, you can have pressure increase when you walk on the tip of the toes, head of what's called the metatarsal. So there is a change in where the pressure is distributed. That is what happens when motor nerves are involved. When sensory nerves are involved, the patient doesn't feel anything. So normally we have this sensory response to avoid danger. So if you're walking on a hot floor or on a beach, or you step onto a stone or a pin, you would immediately withdraw your foot because it's painful. But in diabetes, these sensory nerves are destroyed. So patients don't feel the pain, and any minor degree of trauma then ends up causing more problems because you don't realize you're walking on a hot surface or a pin and you can burn yourself, etc. That's how the sensory nerve damage affects diabetes. Now, the autonomic nerves, so when they are damaged, you get dry feet. So when your feet are dry, they can crack, and that can also be a pathway for bacteria to get it. So the three different nerve involvements causes a change in the shape of the foot, causes lack of sensation and dryness. Now that's the nerve part. Now the arterial part, people with long-standing diabetes have an increased risk of hardening of the arteries, atherosclerotic arteries. And typically in diabetics, it affects the blood vessels below the knee, the smaller blood vessels, and the flow into the foot. So when you have a combination of all of these things that we mentioned about the change in shape of the foot, the lack of sensation, dryness, no circulation, and if you get a wound, then you don't feel it, it becomes very septic, There is no blood supply going down there to heal it. And that's like a ticking time bomb waiting to explode. So that's the main pathophysiology of a diabetic foot problem.
That was really insightful, and also it is so crucial to know that these changes actually impact the circulation and the wound healing process as well. So, in that on that note only, so when you consider these pathophysiological changes, so does your approach shift in terms of early intervention or something like prioritizing certain treatments?
Yeah, I mean, first of all, I think we need to focus on prevention because there's no point in trying to heal things once it's damaged. Yes, there is a point, but it's more difficult to heal. So prevention is better than cure. So if you're a diabetic, if you have diabetes or somebody or one of your loved ones, friends, relatives have diabetes, they most of the times have regular checkups, but it's usually checking the blood sugar and the eyes and the kidneys, etc. And people forget about checking the feet. So if you are a diabetic, then you need to be aware that you have a potential problem with your feet if you do not take care. So when you go for your regular diabetic checkups, you should get your feet checked. So basically, they will ask, they will feel the pulses, make sure the circulation is okay, check the sensation to see if the sensations are okay, and also look for any defects, any calluses, hard calluses that shows that the pressure distribution has changed. And then obviously, you can be given advice of how to prevent your foot getting damaged if you have regular checkups. I would recommend at least once in 6 months. And of course, the patients themselves or their loved ones should look at their feet every day. Morning and night, when you get up, just look at your feet, both underneath as well as between the toes. Just make sure there are no cracks, there's no increased dryness, there's no wounds that you're not feeling, etc. So, prevention is really the key.
So, like, is it like for prioritizing certain treatments? Is it necessary?
Yes, yeah. I mean, if you have, as a diabetic, you have any kind of wound in your leg, whether it's tiny scratch, a small little red spot, please go and see your diabetic doctor or a physician because it needs to be looked at and acted on very quickly for all the reasons I mentioned before about the pathophysiology. If you're a diabetic, you get a wound that in normal people you can just, keep it clean, put a band-aid, it'll heal up. In diabetics, it may not happen. You may suddenly get severe infection and it progresses very quickly. So yes, any little scratch, go and see your doctor. That is very important, and that can prevent a disaster from happening.
That's a great advice, Doctor. Now, from your perspective as an expert vascular surgeon, what are the essential diagnostic steps you use to differentiate between neuropathic and ischemic diabetic foot ulcers? I imagine that this distinction can be very critical for tailoring treatment plans also. So it would be a good advice from me.
Yeah, it's a great question. So, I mean, yes, diabetic foot problems have a combination of nerve and arterial problems. So, you actually need a multidisciplinary kind of care. And yes, you need to differentiate whether it's a neuropathic ulcer, ischemic ulcer, or many times a combination of both. So, multidisciplinary care provided by your endocrinologist, your general physician, your GP, a podiatrist, orthopedic surgeon, vascular surgeon, plastic surgeon, they're all really essential cogs in the wheel to help treat a diabetic foot problem. And if you have a diabetic foot problem, it's always better to seek help from a place where you have a team of these people working together to be able to deal with the diabetic foot. So I, as a vascular surgeon, if somebody came to me, I will do all the normal clinical examinations. I will look for neuropathy as well. I will just see if there's lack of sensation. I will look for dry feet. I will look for changes in the shape of the foot. Are there any hard calluses, maldistribution of pressure? And I will also feel for their pulses. Now, if the pulses are not felt in the foot, by the pulses I mean from the femoral, the popliteal pulse, and the dorsalis pedis and posterior tibial pulse. If they're not felt, I would listen for them with a Doppler and then see if there is a reduced flow. Normal pulses are what we call triphasic on Doppler. There are three phases. As the artery narrows, the phases become two phases, one phase, and it disappears. So I will be looking for pulse deficit as well. If there is a pulse deficit, obviously I will have to investigate that further, usually with a Doppler arterial ultrasound, and follow that up with angiography, either with CT angiography or MR angiography or a diagnostic angiography, the old-fashioned DSA. But the important thing in the acute setting is to see if there is sepsis, just make sure that there is no infection. And if there is significant infection, that needs to be hit hard straight away. So instituting antibiotics, taking a culture, incising and draining any abscesses, and at the same time, carrying on with investigations for the circulation and for the neuropathic problems.
Thank you for that detailed explanation. Now, sometimes it also be like diabetic patients presenting with both neuropathy and vascular disease. So it might be achieving a comprehensive diagnostic, and it can be very tricky. So how do you approach such cases?
So, like I said, we have to work in teams. So we will have to work with a neurologist, endocrinologist, orthopedic surgeon, and a vascular surgeon. So for the neuropathy, well, once the neuropathy is established, there's no real cure for it, but you need to make sure that all the pressure areas are protected. You need good assessment of the foot, gait analysis. See if you can get a good orthotist to give you what is called as offloading, that is footwear that does not damage your feet. Takes pressure off those pressure areas, and this may be in the form of an insole, or it may be in the form of a specially devised boot, or even simple footwear without any rough edges that protect these pressure areas. And from the vascular side, if the circulation is a problem, like I mentioned, we would do an angiogram. And if on the angiogram, there are narrowings of the blood vessels that can be treated either with an angioplasty or with bypass, then we would proceed to do that, especially if the diabetic foot has wounds in it. If there is a wound that is non-healing, and there is a problem with the circulation, it's essential to attempt to try and improve the circulation, to try and get antibiotics down there and get the wound healed. So yes, it has to be a team effort in terms of dealing with a neuropathic and ischemic foot.
You rightly said that multidisciplinary approach does help a lot. Now, focusing on interventions, chronic limb-threatening ischemia is in diabetic foot patients presents a unique challenge. So, what do you say are some of the most effective surgical or endovascular techniques for limb preservation that you have implemented in these cases?
Yeah. So when we are talking about a diabetic foot which doesn't have a wound, but it has neuropathy, and you have already given the advice about footwear, taking care of the foot, etc. So offloading, looking after the feet, moisturizing, wearing the correct footwear. But you have a problem with the circulation, with hardening of the arteries below the knee. Now, we have in vascular a concept called critical ischemia. So if you have a diabetic person with a wound or changes in the feet that cause pain or gangrene or ulcers, then we need to try and improve the circulation. Now, how do we do that? Now, first, the diagnostics, which is an angiogram. And like I said, in the diabetic population is usually the 3 blood vessels below the knee that are affected. So the first course of trying to open up that blood supply would be what we call an endovascular option, which is basically, I was talking about once we make the diagnosis of these narrowing of these blood vessels, we need to open them up in a diabetic patient with a foot wound. So endovascular option is the first option. By endovascular, I mean, you may have heard of the terms angioplasty, etc. So it is exactly like that, like how you would do in your coronary arteries. You would try and pass a wire past these narrowings in the blood vessels and stretch them up with a balloon to try and improve the circulation. And nowadays, we are able to intervene in small blood vessels, even in the foot. Sometimes we have to go from the groin, sometimes we can come from below upwards as well, and sometimes a combination of both, getting a wire across, stretching with a balloon. And also the balloons have now been upgraded into what we call as a drug-eluting balloons. So there are a group of drugs which used to be used for transplant patients, things like tacrolimus, sirolimus, etc., which are incorporated into these balloons. And when you inflate the balloons in the narrowed artery, the drug is delivered into the arterial wall. And the reason we do that is to try and increase the patency of the artery. That is, we prevent something called as neo-intimal hyperplasia. So when you actually stretch an artery up, you're cracking the plaque and causing a little bit of damage to the walls to make it stay open. Now, these drugs have been known to reduce the amount of proliferation of cells that can re-occlude or re-block those arteries. So drug-eluting balloons, wires that are very small that can go into the foot arteries, balloons that can reach those foot arteries, have all improved our ability to try and do endovascular opening up of these blood vessels. In the past, there was a time when very small blood vessels in the foot were involved. You would say there's nothing much more that can be done. But nowadays, with these new technology, hardware, and good software, good imaging, we are able to go down to those blood vessels and open up those blood vessels. And the main aim is to heal any wound and prevent an amputation, prevent a loss of limb. Now, sometimes endovascular options don't work. And then, of course, there is a surgical option many a time, and that is what is called a bypass. Just like how you would bypass a blocked blood vessel in the heart, you would do a bypass the blocked blood vessel in the leg as well. And usually it's done by using your own vein, taking your vein from your leg, reversing it and stitching it above the blockage and stitching it below the blockage. So these are the ways we try and improve the circulation to the feet in patients with diabetes.
That's such a powerful perspective on preserving limb function, especially, when they are given the risk and the high stakes that are involved in such therapies. So, yes. But now, for patients at very high risk, especially those with severe infection or ischemia, how do you balance between conservative management versus surgical interventions, such as, amputation when absolutely necessary?
Yeah. So sepsis is a big problem with diabetic feet. Now, if you have sepsis, a big abscess in the foot, there is really no role for conservative management there. You have to get rid of the pus. So it is a surgical emergency. A diabetic person with an abscess, sepsis in the foot is a surgical emergency. So you need to do the basic surgical techniques that you would do for any sepsis, anywhere abscesses. You need to drain it. You need to give it a good washout. You need to get rid of all the tissues that are necrotic and infected. You need to get a good pus or wound culture, send that away. Start even before the pus culture comes. You should be aware of your local antibiotic antibiotic therapeutic process. You should be aware of what bugs are prevalent in your community. Everybody in different areas have different bug profile or bacterial profile. So you start antibiotics empirically straight away. And then when the culture comes back, obviously, if you need to change the antibiotic, you should change that. Once you've drained the sepsis, you need to regularly inspect that area. If it needs more drainage, multiple debridements, you may need to do that. So it's aggressively hitting the infection, because infection is one of the key things that can lead to limb loss. So you are trying to prevent an amputation here. So the key is that if you have sepsis, it is a surgical emergency. You need to approach it with the basics of surgery anywhere where you have sepsis. Drain the sepsis, get rid of the necrotic tissue, wash out nicely, inspect it regularly, get a good culture, start the appropriate antibiotics. So that is how you go about dealing with sepsis.
Yeah, it is so insightful to hear that how critical this decision-making process would be. Now, lastly, patient education is essential in preventing the reoccurrence of diabetic foot ulcers. So, how do you engage patients in post-operative care to help reduce the risk of reoccurrence? And are there any specific strategies that you find particularly very effective?
Yeah, that's a very good question. I mean, I don't find it difficult in the post-operative stage to encourage people to think, because they then already know what the danger is. that they potentially could have lost that leg. So for those group of patients will follow your instructions about inspecting the foot, wearing appropriate footwear. It's the prevention, the patients who have not had any problems, who are diabetics, those are the group that we have to get into and try and get them to realize that diabetes is the commonest cause of non-traumatic amputations around the world. And what we perceive as a small little wound in anybody else, for this group of patients can be a threat to the limb and sometimes threat to life. So they are the group of patients we need to concentrate on and educate. And it needs to start with your family doctor, obviously, which is your normal point of contact. So when the diagnosis of diabetes is made, a foot check needs to be included in that on a regular basis. You can give leaflets, you can point them out to diabetic groups or diabetic foot groups. There are several available on the internet where they can get more information. Many a time it's difficult for patients and doctors who are a busy clinic to sit and have long chats about these things. So getting them through diabetic educators, family medicine doctors, internet groups, so lots of WhatsApp groups now that are diabetic foot amputees or survivors of that. So it's the group of people who have not had a problem that are more important to educate. Those who have had a problem, they've already sort of learned their lesson and they are obviously very aware of the problem and they will take care.
Yes, that is rightly mentioned that they actually know what exactly it takes to be there. So yes, they will take. And I think education is very important, and the right kind of education is also important.
Yeah.
So, Dr. Riza,
Absolutely.
thank you so much for sharing your expertise with us yet again today. And diabetic foot is such a complex and impactful issue, and your insights have highlighted not only the challenges but also the advancements and care strategies that are making a huge difference today. So, thank you so much, Doctor.
Thank you. Thank you. It's a very important topic. And yeah, if we can prevent amputations because of diabetes, that will be a fantastic thing. And simple measures and being aware can prevent that.
Definitely, awareness is the key. And to our audience, thank you for tuning in again. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, as the doctor mentioned, stay aware and take care.